Sorry, I like to move around a little bit. I have trouble standing behind a podium sometimes. First of all, I want to thank all of you for coming out today, coming out this morning, taking time out of your day to learn a little bit more about cannabis and what it has to offer. It's really a truly exciting time here in Florida that we now have an opportunity to discuss this and begin to think about the use of it as a patient. I also want to point out, and thank Knox and Certera in the back. The two dispensaries really have transformed the industry in Florida. They're very innovative. They've come out from the very beginning to help develop products that have shown really high quality and really with the patient in mind. It's kind of always been their goal, is what I've seen. So please take the opportunity to take advantage of meeting with both Certera today and also Knox. It's not every day that you'll be able to get, as Florida market develops, get all the dispensaries together in one area. So please take advantage of that. I wanted to just to get started, I'm with Medical Marijuana Treatment Clinics of Florida, just so that you're aware, with Dr. Beasley here in the back. You'll be able to speak with her a little bit later on today, and also Dr. Joseph Dorn, who's our Chief Medical Officer, who has a clinic over in Tallahassee and Jacksonville and a few others. Just to provide you with a little bit of background and information about myself, like Mark said, I'm a pharmacist by nature. I relocated here to Florida about 8 years ago with my wife from West Virginia. It's where I grew up. I'm a transplant here to Florida, like many of you. Kind of found that once I moved here and left the cold in the winters, it's really tough to go back, and I think many of you would agree. Spent a little bit of time in Pensacola and absolutely love it here. Well, I tell you all this, as being a pharmacist, I wanted just to let you know, while working behind the counter as a pharmacist, I had the opportunity to work in places like Walgreens, Rite Aid, Kmart's, which are far and few between as a pharmacist. I had the opportunity to work in hospitals, both very large and also very small. I've worked in a VA, working with patients in that type of outpatient clinic. I've had the opportunity to work in an inpatient psychiatric hospital. I've met patients from very diverse backgrounds, all different walks of life. And I've seen a lot of patients that are really out there suffering. Patients with seizure disorders, cancer, multiple sclerosis, chronic pain, post-traumatic stress disorder, to name a few. I've met with the mother at 2 a.m. with her child, with a cough or a cold. As I've met with patients and I reflect, it's always been my goal to help make a difference in patients' lives. It's really part of the pharmacist code. That's why we're there. That's what we try to do. And while many patients would do well on traditional pharmaceutical therapy, quote unquote, Western medicine, what I found a lot of times as a pharmacist is that, really many did not. And some that did okay could have stood to do a lot better. And like many of you, I really thought to myself, what's going on here? There's got to be something more, right? It's 2017, and we're still battling with these types of things. At the end of the day, your health is everything, right? It's your quality of life. If you don't feel well, most oftentimes you don't do well. And it started to open my mind to alternative medicine, just like a lot of you guys that are here today, really all of you. And I had the opportunity to work in what's called compound pharmacy. Is anyone familiar with compounding or anything like that? Some hands in the back. Yeah, it's a very interesting profession where you get to take different medications, mix them together. A lot of times capsules, creams, solutions, topicals, things like that. And they're really designed for patients that don't necessarily meet the traditional mold. And it really opened my eyes. A lot of patients did a lot better with customized type therapy, not the one size fits most, big pharma type approach. You know, and as I sat there, you know, working as a pharmacist, from time to time I'd have patients come in, you know, as I gained a relationship with them, to let me know, you know, Cameron, I use medical marijuana, or it really wasn't medical at that time, quote unquote, called medical marijuana, but they would let me know that they used marijuana. They wanted to know what my thoughts were about it, you know. And at first, I really didn't know much about it, honestly, a few years back. A lot of them would come in and tell me, it really helps with my pain. It helps me, maybe reduce their opioid use, or it helps with sleep, things along those lines, which I thought was really unique and really powerful, and I really wanted to know more. Like all of you, we've seen this movement throughout the country. It started in Colorado, and I'm there working behind a shelf thinking, what's going on here? What's going on with these people? What's happening, I wasn't really necessarily taught about cannabis in pharmacy school, much at all, aside from drugs are bad unless they're big pharma drugs, honestly. I met a doctor recently, a brand new grad, sharp guy, who made a comment that in all of his medical school training, not once did he learn anything about the endocannabinoid system or anything about cannabis at all. And it was very shocking to me, but it's the reality of what we're in. At medical marijuana treatment clinics of Florida, all we do is focus on cannabis and cannabis evaluations. There's a lot of misinformation out there, a lot to learn. A lot of doctors, for example, have misinformation, and providers like Dr. Shelley Beasley and Dr. Joseph Dorn have really began to dedicate their practice to alternative medicine and learning more about it. I think they're a very valuable resource that you guys should lean on, especially while you're here today. As far as my knowledge with marijuana, like I mentioned, it was very limited. I thought everything with marijuana was very black and white. You either got high or you didn't, and if you didn't, you were clearly doing it wrong. I was very naive. I had a lot to learn, and on my adventure, as I mentioned, growing up in West Virginia, I saw a lot of pain, a lot of suffering, a lot of poverty. I saw a lot of families ripped apart from the opioid epidemic that really has a stranglehold on my home state. And I think most of us would agree that we know somebody that's probably struggled with addiction or struggled with opioids, whether it's a friend, a family member, a relative, something along those lines. And when I moved here to Florida, what I began to find is, honestly, it was no different. Florida was going through the same crisis that we were back home in West Virginia. It was right up that Appalachian Trail. And it was scary. So, I would think to myself as a pharmacist, well, is cannabis a gateway drug, right? I think we probably all thought that. And what I found, in some ways it's true, cannabis to some degree is a gateway drug. If you find that patients that use heroin or cocaine, right, recreationally, they're more likely to have used marijuana previously. But what's much, much, much more likely than that is that they were to begin by using alcohol or cigarettes, and typically at a much, much younger age. I had questions about dependency, what, as a pharmacist is something you need to think about. And what I found is, with cannabis, the dependency on cannabis is right there with caffeine, or even slightly lower as far as dependency goes, whereas these opioids that we prescribe daily to patients are over 3 times higher, but that seems to be okay. Josephine touched on this slide a little bit ago, but it was kind of part of my voyage and likely part of yours. It's this U.S. patent 6630507, which I think defined a little bit hypocritical to some degree of the government, where they have the IP, the intellectual property patent on cannabis. It's on the medical use that it can be found to protect the brain from damage or degeneration. Well, at the same time, as you're thinking about this, the DEA has it listed as a Schedule 1. Cocaine is at least a Schedule 2, so it's more dangerous under, classification of the DEA than, Vicodin, Percocet, Oxycontin. And as a Schedule I, it shows no medical use in the eyes of the government. And when you think about this, it just seems very hypocritical to me. But I also understand that it's not so black and white. There's, obviously more to the situation. But it's got to make you stop and think for sure. Well, I started to think to myself, as I wanted to get involved in cannabis, what does a marijuana patient look like? Maybe you guys have thought about this. To me, of course, it was Snoop Dogg and Willie Nelson, right? Oh, Willie, right? Yeah. I mean, they clearly used cannabis. Whether they use it for medical purpose, I'm not so sure. But that was my, my original, that's how naive I was. Those were my original thoughts. I mean, maybe, hopefully some of you all had those thoughts too. Don't leave me hanging. But, I'll tell you what I found that a cannabis patient looks like. It's the coal miners. It's the blue-collar workers. It's the accountant, the attorney. We have several pastors from a church in our clinic, which has been amazing. Having the opportunity to use cannabis now here in Florida, I think, is very exciting. There's, really, if you talk to the dispensaries, which see patients from all walks in life, I think they'll tell you that it's a lot of friendly faces that we see out there. What I found that a cannabis patient looks like is a lot like, really, me and you. Just your normal, everyday type of patient. So I put this slide up here that Josephine talked on a little bit, but I wanted to talk about it kind of from a treatment standpoint. Whenever Amendment 2 came out back in November, I have a very strong passion for endocrinology, holistic type medications like all of you here to some degree. And when Amendment 2 came out, I knew I wanted to be involved. I want to help people make a difference. I want these alternative types of therapy. And what Amendment 2 did, as you all can read here, is it expanded the medical conditions to include cancer, epilepsy or seizures, which was covered originally, glaucoma, PTSD, ALS, which is Lou Gehrig's disease, Crohn's, Parkinson's, and multiple sclerosis. But I get questions all the time about this caveat at the bottom, so I thought we should talk about it. And this is where I think the state really got it right. The amendment goes on to include another debilitating condition of the same kind or class as, or comparable to those listed above. What that really allows is for, it kind of gets the state out of your way, to some degree for once. Let's the decision go back into the doctor's hands of what may or may not be found to be comparable. I can tell you the majority of our patients at MMTC, about 60%, don't necessarily have one of those conditions, but what they do have is another condition comparable to that may be debilitating. For example, we've got lots of patients with debilitating anxiety that use cannabis. We've got patients with degenerative disc disease. Really interesting cases of patients with Lyme's disease, spasticity, migraine sufferers. Really, in a lot of ways, if you have some type of chronic medical condition that you seek treatment for previously, there's a really good chance that you would qualify for cannabis under current law. You should certainly feel free to reach out to us about that, and we can help you along the way. I think Dr. Dorn will make some comments on that here in a little bit. So you might sit there and be thinking, like Josephine was, and I certainly did as a pharmacist, when it came to cannabis, how can it be used to treat so many different things? How is this possible? What's really interesting is the National Institute of Health came out and said that the endocannabinoid system is involved in virtually all disease states. The way I like to think of it, really, with cannabis is curing or mitigating, like Josephine said, a nutritional deficiency, or helping maintain homeostasis within the body. I mean, if you think about it, if somebody has seizures, right? In their brain, it's this overstimulation, right? This abnormal firing of neurons. So what cannabis can do to help bring back homeostasis, it helps balance that, helps calm it. Patients with Crohn's, ulcerative colitis, they have a lot of inflammation in their stomach, right? So cannabis works in ways as a very powerful anti-inflammatory, different than the typical anti-inflammatories like ibuprofen that we take on the market. Cannabis in and of itself is known to have over 480 known components. It's not just an ibuprofen, not just a tablet. It's much more than that. There's many different products or chemicals going on here, and many of these are the cannabinoids that we're after. I want to show you a picture here. Maybe you guys have seen cannabis before. Most of our patients have from time to time. But if you look at the picture here on the bottom right, it's what we call a trichome, right? So it's this waxy ball of substance that's on the marijuana leaf. What that contains is really the medicine that we're after for the most part, and it's what the dispensaries are after. You should talk with them about some of the extraction processes. It's really great. That's where we get a lot of our CBD, our THC, our terpenes, our flavonoids, and all the other type of chemicals that can make cannabis work so well for different patients. In different plants, like the one on the top left, you can actually see the trichomes without magnification, have different combinations of CBD, THC, terpenes, and the others that might help one patient with a specific disease state over another. So lots of really interesting stuff out there with cannabis that we're learning about. It's really so rich in information and possibility. Well, I'm talking about terpenes, like she mentioned there earlier today. A lot of patients that want help with sleep, something like that. You can use something like linalool or myrcene. Myrcene is like lavender, right? So a lot of times we use aromatherapy and lavender to help calm us. Linalool from hops. You'll find hops in beer. I think anybody, terpenes in and of themselves aren't only specific to cannabis. If you drink a glass of wine, you'll be, taking in, different terpenes. They're all out in the elements. Limonene, of course, is easy to think of. Lemons, pinene, pine. And those are just parts of the value that are in that cannabis plant with over 480 known identified chemicals. Here's just an example of the cannabis plant. We often talk about CBD and also THC, but within that trichome, there's a lot of other products that work on inflammation, pain, nerve conduction, and a lot of other processes, which is really exciting. I put the slide up here just so I could show you. I think it's very important to note this. The gentleman on the bottom left, his name is Raphael Mechoulam, okay? And he is known as the grandfather of modern cannabis research. He has been given credit for understanding and characterizing the endocannabinoid system, okay? He's really been a pioneer, did most of his studies in Israel to help, help us get a better understanding, get us to where we are today. But in addition, to that, there's a lot of studies that we have available that come out of Canada, Australia, Spain, Italy. And, what we often hear as medical professionals and also as patients is that there's no medical research. There's not enough information on cannabis out there. How do we know it works? I hear it all the time from friends, colleagues. A lot of times I think we get a little bit lazy, and when we don't understand something, we just try to put it down that way. And I really wanted you guys to see this. I thought it would be interesting to you. So as a clinician, a pharmacist, a nurse, a respiratory therapist, a doctor, anytime we want to learn more about a new medication that's coming out, a new disease state, what's the latest, what's the greatest, here a lot of times we'll use a database called PubMed. And what PubMed is, it's where you can find peer-reviewed articles, studies, journals, publications that are released to kind of learn and stay on top of the latest and greatest. Well, what's very interesting to me is all the time there's put out, even in the media, you know, senators, it goes on and on, that there's just no research out there on cannabis. The other day I typed marijuana into the PubMed search where we go to get our information. And what came back is 25,510 peer-reviewed articles or journals related to marijuana. If you were to type in hydrocodone in the same section, hydrocodone, again, that's Percocet, Oxycontin, morphine, same drug class, you would find 960 studies. If you were to type in Adderall, which is an amphetamine that we give to our children, you know, for ADD, ADHD, you'll pull up 201 studies, but all of a sudden that becomes okay. That narrative is fine. Now, while I would agree with you completely that we could use a lot more studies and we're getting a lot more information on the different cannabinoids every day of the week, which is exciting, I think we have a really good place to start, truly. So if you could leave here with any information at all, I think, you know, helping dispel some of these myths and rumors is very important. And especially at a time where the CDC says that the United States is in the midst of an opioid overdose epidemic. You know, what if, you know, cannabis could replace some of these different type of medications, you know? This chart I wanted to include for you to see here. If you look at the blue line, that's the one on the very top. Those are deaths associated with poisonings from different types of medications or drugs. And at the very top line, those are the prescription opioids, the morphines, the Percocets, the Vicodins. Where at the bottom is cannabis. There's been no attributed overdose related to cannabis ever. More important and more exciting to that than me, you know, from the World Health Organization, they put out a publication titled The Health and Social Effects of Non-Medical Use Cannabis in 2016, and they also reported finding from the WHO no reported fatal overdoses in the epidemiological literature. When the WHO says that, that means there's no overdoses related to the use of marijuana in the world, and that's a big deal. In pharmacy school, I remember learning that you could overdose from water, okay? And in a lot of ways, it's related to the receptors in the brainstem and things along those lines. Kind of cool, a slide I put up here on the top right, I thought it was neat. It's the ratio of fatal dose to effective dose. So right in the middle, you'll see alcohol. It's kind of a third the way up. And alcohol is given a classification as a 10. So what that means is if 2 shots got you drunk, then 2 times 10, 20 shots would be likely to kill you. What's kind of cool is right below that, right on the same line, is dextromethorphan. Does anyone know what dextromethorphan is? Right, it's a cough suppressant, and we sell it over the counter. I personally don't have any problem with dextromethorphan. I've recommended it thousands of times. I think it does well. But I think it's important to note, the safety ratio here between things that we're taking over the counter and cannabis needs to be considered. What if it really is safer for many patients than the medications it can replace? Just like you guys at home at night, I watch television from time to time, and I see these commercials on TV about these new latest and greatest medications coming out. They paint this beautiful picture, husband comes home to the wife, everybody's happy, and I'm telling you this as a pharmacist, from my experience. I mean, I was behind the counter dispensing these types of medications, and many medications are great. But at the very end of these commercials, you hear this long list of adverse effects, right? And it's like, it's this pretty picture, and it's da-da-da-da-da-da-da. And some of them even now, it may cause death. So I can tell you now, from the medical use, there will be no, there's no reported fatal overdoses to the use of cannabis, which I think is pretty powerful. Put here a study that I think you might find interesting. At our clinics, our average age is around 54, 54 and a half. We've got patients that are 90, we've got patients as young as 21. Johns Hopkins, a very prestigious university, of course, and Temple, they did a publication where they looked at different states that had cannabis laws in the books, and they went and they looked at how medical marijuana has affected this type of population with regards to employment. And what they found is that there was 9.4% increase in employment, from patients using cannabis, which I thought was really powerful. Now when I retire, I don't know that I'll be running back to work, but you know, if you think about it, this is particularly true in men. If you feel well, again, you do well. And a lot of patients we come across on a daily basis are just looking for something more, you know, a way to get more out of their life. And I think cannabis is, you know, really amazing opportunity for some patients that can really help. You know, and where do I think we're headed, you know, with cannabis and pharmacy and doctors, and as all these states progress, you know, you saw California, you know, Colorado, Washington, Florida in the books, Texas just happened, now they've got legalization there, West Virginia. And I think what we're running into, which is going to help the profession and help you patients, is what it's all about, is a lot of standardized medicine, really, which seems to become more acceptable to patients, first of all, and doctors as well. And what I think is really cool about it is you can finally know your dose to some degree, what's going to work for you. I get patients all the time, you know, they'll call in and talk to me, and if you're a patient of MMTC, we probably talked before, and they'll say, you know, I use cannabis recreationally, I get it from my buddy or whatever. You know, okay, that's fine. And they want to know how much to use, right? And you know, it's a fair question, but what's very difficult to know is from what you got from your friend or buddy or whoever, is what really is in that, you know? And what's really amazing is what Sotera and Knox do at their clinics, where they make their products, is they dial in and they can figure out within a certain very strict percentage exactly what is in each dose that you're going to receive. You can finally figure out what you need to get better, and it takes all the guesswork out of it. And I think that's really amazing and powerful. Sublingual drops, tinctures are out there. Like she mentioned, both companies here have those. Sotera has a spray, which is a little bit unique to them. Knox has capsules, which is a great dosage form, and they're working on suppositories, topicals, things along those lines. I had a patient come up to me recently. This was her words, not mine, but I thought it was really cool and powerful. She said, you know what, Cameron, you know, the topical's working for me, right? I'm like, oh, that's great. She says, I don't need icy hot anymore. It's my icy pot. And I was like, I just thought that was great. So I borrowed that from her. But I think it's really neat and really powerful. I wanted to throw up some questions that I get all the time at our clinic, because I thought, if, you know, I had them at one point, patients have them, maybe some of you guys have them too, and I'll try to address some of those here. So I hear all the time, I'm nervous about using cannabis, I want to get high. I don't want to get high. Well, just put my foot in my mouth now. What's really funny is if you look at the studies of patients that use medical marijuana, only 15% report that they actually want to get high. So if if you're probably, if that's your thought, you're probably in the majority. So with about 100 people here, could you 15 raise your hand that are using it? You know. Just kidding. I get questions a lot about what dosage forms should I choose, right? Great question. And you know, really it depends on you. Our doctors that I work with, I think they'll back me up on this, is that they're here to support you and what makes sense for you and your lifestyle. If you like vape, we'll do vape. If you want to do sublingual drops or capsules, that's what we're going to do. And really, a lot of patients do well from a combination. Capsules have some advantages, right? So they take a little bit longer to work, but they'll last for a longer duration. Vape has some advantages. It'll work quicker, but it can wear off. So some patients will do, for example, sublingual drops 3 times a day if I'm a chronic pain patient, and I might do vape as needed throughout the day to give me relief when I get it. I hear from fibromyalgia patients all the time. You know, some days are really bad and some days are really good. So having that availability to self-adjust works well for them, and I think it's important to know. Something you should be able to do. What is my dose, right? And I get that question all the time. And I'll be honest with you, I don't know what your dose is. I have a really good idea from the studies what your dose is going to be. But cannabis is unique. You know, say you have high cholesterol, right? A lot of different options we can treat you for with statins and things like that. And we know if we give you 10 milligrams of this, we could take 10% off. your cholesterol level. With cannabis, it's so individualized. It's, you know, bringing back that homeostasis that we talked about. Someone may have more receptors than others, more endocannabinoids than others, and really working together with your doctor or self-adjusting over time is really what's important to really understand that it's really, you're the driver in a lot of ways of this. It's your feedback. Everybody's different. How soon should I see results? I get that all the time in all types of, you know, with all medication. And really it depends, honestly. You know, a lot of patients with pain and things like that, they'll do really well pretty quickly. You know, some patients can do well after a dose or two. Those patients are generally in the minority. It takes consistent dosing over a period of time. Disease states like Parkinson's, for example, on average it can take 3.2 months to really start to get control, really with regards to tremors. If it's something like sleep, a lot of times that can be a lot earlier on. So it really depends. It's my philosophy with cannabis and our doctors as well is to really start low and go slow, titrate up slowly to find what dose makes sense for you. And there's really a lot of information out there on low microdosing and really doing yourself justice by taking your time to gradually get to where you need. Like I mentioned earlier, a lot of patients don't want that euphoria from cannabis, and I'm here to tell you, to get better, you don't have to have it. You know, if you can get, a lot of patients don't need any of it at all, and you can take THC and not get high, not get a euphoria easily. Just because it's there doesn't mean you get high. It's just doing low, consistent doses to help with inflammation, neurotransmission, and things like that. Starting low and going slow is the key. I remember a specific patient that came in and they were suffering from Parkinson's. And patients with Parkinson's do really well on both CBD and THC. And she said to me, you know, Cameron, she's speaking for the husband, which seems to happen a lot. My wife speaks for me sometimes. But she said, we're not doing that THC stuff, right? And I said, okay. You know, what are your thoughts on it? You know, what's going on here? And you know, and she's like, you know, and she had kind of the misconceptions that I had when I was learning. You get higher, you don't, you know, that kind of thing. And when I began to explain to her that, you know, you can use THC slowly with consistent low doses and improve your outcomes, she said, well, let's just do a little bit. I said, okay, let's do it. So we started her on a ratio around 5 to 1 of CBD and THC, and gradually, you know, starting there, gradually to try to improve this gentleman's outcomes. She called me within 3 weeks and said, can we get some more of that THC stuff? He seems to be doing better. So, you know, I would remain open-minded. Don't be scared. You know, go low and slow. That's my motto, really, with most anything related to medication. How do I get a medical marijuana card? Turner's going to talk about that a little bit later today. Don't stress out too much about it. There's a lot of information about how it works, and those are details that you'll want to see. But if you can fill out a credit card application or something along those lines, it's really easy. Demographic type situation. Who will know I'm using cannabis, right? I would want to know that. So really, it's up to you. You're pretty much the driver. Your cannabis doctor, of course, is going to know you're using cannabis. The state police, they do have access to a database, so if you were to get pulled over with it on you and they said, hey, do you have a prescription for this? Give them your name, number, your ID, they'll pull you up. Okay, you're good to go within Florida, which is pretty cool. At the moment, unless, other than those you tell in the dispensary, that's who has that information. You know, I like when patients are able to be open with their providers, their doctors, to let them know. It helps them co-manage patients that are on cannabis. From my experience in Florida, we receive a lot of referrals from other doctors for their patients to come to us to receive care. For the most part, physicians have been really receptive to patients using cannabis. We haven't really had any problems of any, but it's a fear people have. You know, will I be kicked out of treatment, that type of thing, and it's you know, something that you can, you know, kind of feel your way around and talk to your provider about, but for the most part, I'm not seeing it at all. It's kind of funny, especially in Silicon Valley, if you were to drug test your employees for cannabis and your patients, you'd have no patients and employees, and I think Florida's already starting to find that out, which which is pretty interesting. As a pharmacist, common adverse effects, what Josephine talked about, really it's, you know, it's the run-of-your-mill stuff that you're going to find with any other medication. Drowsiness, dizziness might be a good thing, you know, if you're looking for some drowsiness, something along those lines. You can find products at Knox, for example, that are tailored to help with sleep. They have some more of that linalool, some more of that myrcene. And then there's other strains that Certera has, and Knox as well, that don't cause that. If you're a patient that's just interested in using CBD only, which is fine. CBD is great, strong anti-inflammatory. You'll be able to find a CBD only type product at Certera called Calm. You'll find Alcor or Rigor from Knox. You should talk to them about it. Really great product. You know, there's potential for blurred vision, dizziness, a little bit of anxiety, potentially. Well, it can also treat anxiety. It's all about going low, going slow, finding your effective dose there when it comes to all of that. A listing again of the conditions that we already talked about. Reach out to us at the table. I think, and that's me with Medical Marijuana Treatment Clinics. So thank you all again for attending. I hope I was able to help with some information. Really appreciated meeting many of you so far. Please come over and meet us and let us know in what way we can help, okay?